Let's begin with Chapter 9 Safety and Quality. Let's begin with QSIN Quality and Safety Education for Nurses. This is a topic and organization you'll hear come up a lot, and it focuses on things like patient family centered care, collaboration and teamwork among the healthcare team, evidence based practice, quality improvement, safety, and informatics. You're going to hear the term the six rights of medication administration a lot throughout this program, and that's especially true here in pharmacology. And these six rights are the right patient, drug, dose, route, time, and documentation. And there is a handy acronym that can be used to help you remember these as well. And that is patients do drugs round the day. Right patient, dose, drug, route, time, and documentation. We begin with the right patient, and this determination is essential. We're going to verify the patient with two forms of identification. Everything from comparing the patient's stated name and birth date with the patient's ID band in the MAR. You can also scan the patient's barcode on their ID band. Check the color coding on the patient's ID band. Verify the patient's name with family member if present. And check for any name alert stickers. These will be used when you have two patients on the same hospital with the same name or a similar name. The next would be the right drug. We're going to scan that medication label, check the order is prescribed by a licensed healthcare provider, read the drug label 3 times, be familiar with the patient's health record, allergies, lab results, and vital signs. Know why the patient's receiving the medication and if it's correct for the patient's diagnosis. Always remember, you are the healthcare professional there at the bedside. You also want to check those dosage calculations carefully and know the beginning and ending date for the order. Next would be the right dose, and this requires verification by the nurse that the administered dose is both the amount ordered as well as safe for the patient. This is going to be based on things like the patient's physical status, their correct dosage calculation, verify that that drug is safe, weight of the patient if it is a dose dependent medication, and also validating the dose of certain drugs like insulin and heparin by getting a second eyes on that syringe. And these are drugs that are always verified with two RNs due to the danger of a mistake. Next would be the right time. Are we giving this at the correct ordered time, correctly spaced out from the last dose as well? The time of the prescribed dose is ordered for administration. We're always going to use military time to reduce errors. Every aspect of healthcare, we are using military time. We're going to closely follow our agency's policy. Be aware of any drug affected by food that are given within 1 hour or two before meals or 2 hour after meals. Give the food with drugs that irritate the stomach. Check for scheduled procedures, expiration dates, administering antibiotics at those even intervals, and holding in any antihypertensive meds prior to dialysis if ordered. Next, we're going to look at the right route. Is it PO, IV, IM? This is going to be necessary for adequate absorption. Assess the patient's ability to swallow oral meds. Do not crush or mix medications without validation or consultation, because it's going to be key. We never want to crush an extended release capsule. Offer the patient water, but not juice. Iron may be taken with orange juice, though. That's a subject that's going to come up a lot. Is when in NCLEX and ATI really loves that question as well. Is that we always give acidic fruit juices like orange juice to a patient who's taking oral iron because that helps to increase its absorption. That finally would be right documentation. This requires the nurse to record the appropriate information about the drug administered. We want to do these in real time as well. We don't want to be sitting there. We don't want to give our meds and say we'll come back later and we'll document. Because what if there's another nurse? What if something happens? What if another nurse is coming in here, thinks you're behind on your med pass, and gives that patient a second round? We want to be clear, objective, and be documenting medications especially in real time. This would include the drug name, dose, route, time, the nurse's signature or initials according to policy. And we also want to document the patient's response, especially when we're looking at analgesics, antiemetics, and documenting and assessing to make sure that they were effective. Safety is going to be a top priority in any aspect of nursing, but especially in pharmacology. We want to embrace change in culture, so reporting errors don't result in the person blamed, but rather a failure of the system. We never want someone that made a med error to be afraid of reprisal and try to brush it under the rug. Our top priority is going to be to assess this patient and maintain patient safety. We don't want them afraid of reprisals. We want the top priority to identify where was the lapse in our error? Were these six rights followed? Was there some sort of organizational thing that we can correct to help prevent this from happening in the future? The Joint Commission has a do not use list and other list of error prone abbreviations. And these are going to be abbreviations that could be confused or misinterpreted. It commonly results in med errors. These abbreviations have been used for a long, long time. But unfortunately, they can also look similar to other abbreviations or could create a miscommunication that results in an error. Med reconciliation is going to be another topic that comes up a lot and is critical for maintaining patient safety in between facilities. In this case, we want to develop an accurate list of the patient's medications. Advise the patients to bring the medications they're currently taking with them to their first appointment with the meeting. This will go a long way in helping to make sure we're accurately identifying everything that they're taking. The med rec would include everything that they're both prescribed, as well as any over the counter medications they're taking or any alternative CAM therapies that they're taking. Proper disposal of medications is another important factor. You want to transfer the drug from the original container to an undesirable substance like kitty litter. Place the mixture in the container, such as a sealed plastic bag. Remove all identifying information on the label before disposing of the empty container. Do not flush drugs down the toilet unless specifically instructed, as this can be a major source of contamination. There are many cities with rivers that test positive for psychiatric medications like SSRIs. Sharp safety is going to be another major factor. Unfortunately, a needle stick injury, a sharps injury, can have devastating effects and can be very stressful and traumatic. We, just like with our medication errors, we never want to make this a punitive thing. We want them to come to us if someone on staff has an injury. We want them to report it, follow the protocol, and receive treatment. We also want to do everything we can to prevent these from occurring. I have known, fortunately not to me, but I've known some nurses who have had needle stick injuries. And it can be very stressful as they wait for the results and follow that policy. It can be several weeks for them to know definitively whether they've contracted something or not. Other safety risks for medication administration would be things like tablet spitting, buying drugs over the internet, and receiving counterfeit drugs that may look like the desired drug but have the wrong ingredient or dose. They may also be improperly packaged or contaminated. Remember to encourage your patients to only buy drugs from licensed pharmacies. Unfortunately, there are a lot of foreign websites, foreign drugs coming from places with much, much lower safety standards. Other dosage forms, especially when we're placing medications down an MG or a peg tube, we would crush those medications. But at the same time, there are medications we shouldn't crush, especially anything extended release. We want to consult the pharmacist, the healthcare provider, or other drug source regarding which medications can be crushed and which cannot. We also want to be aware of high alert medications. These can cause significant harm if given in error. Examples would be things like epinephrine, insulin, nitro, potassium, chloride. Simplify storage, preparation, administration. Make sure we are very carefully reading medications. Now, I know it's busy on the floor, it is busy at the bedside, and you're going to do a lot of repetitive medication. But at the same time, it's that repetition where things can become complacent and mistakes can happen. We want to limit access to high alert medications, use very clear labels, monitor the patient's response, and carefully go through those six rights of medication on every medication that we administer. Some of these look-alike and sound alike drug names include ephedrine and epinephrine, diazepam and diltiazem, Zyrtec, Zyprexa, Solumedrol versus Depomedrol, and we want to be very careful. Especially you're working nights, you're working long hours. Never become complacent when giving medications. Other factors in prevention of medication errors would be a medication safety zone or a distraction free environment where the nurse can pull their medication from the Pyxis and have a quiet counter where they can prepare their med pass, free of distractions, questions, other conversations, and really focus on what they're doing. As with all aspects of nursing, we want to recognize cues and use our critical thinking skills to determine if medication is safe to administer. Any need for health teaching, anything the patient needs to be aware of while taking this medication, any adverse effects they need to immediately report. We also want to calculate the doses accurately, verify if necessary. Don't just take the machine's word that the math is correct. Actually do the math yourself. You are the professional at the bedside. We also want to be very proactive and take action. Using relevant sources, calculate doses correctly, avoid any skin contamination or inhalation of substance to minimize exposure, always using hand hygiene before administering drugs, never administer medications that another nurse has prepared, and use two forms of identification when identifying the patient. For pregnancy categories and subsections, we want to be very, very careful for any patient that's pregnant or any patient that could possibly be pregnant. We want to provide explanation on any currently available information on the benefits and risks of medications they can have on both the mother as well as the fetus or a breastfeeding child. For our first practice question, which of the following medication groups is the nurse not required to chart the patient's drug response? Would that be A, opioids, B, antiemetics, C, sedatives, or D, antihyperlipidemics? And that answer is obviously going to be D, antihyperlipidemics, as in almost all situations, that patient is not going to show a response without us drawing labs. The next question, what is the primary purpose of self medication administration? Would that be A, to cut down on the amount of staff needed in the healthcare facility? B, to empower the patient to be more effective in management of their therapeutic regimen? C, to decrease medication errors? Or D, to decrease the time the patient needs to wait for the medication? And that answer is going to be B, to empower the patient to be more effective in the management of the therapeutic regimen. And finally, for question 3, federal and state law govern who may prescribe a medication order. Which of the following has the authority? Select all that apply. That'd be A, a medical doctor, B, a licensed practical nurse, C, a certified nursing assistant, D, a dentist, doctor of dental surgery, or E, the advanced practice registered nurse. And that answer is going to be A, D, and E, the medical doctor, a dental doctor, or the APRN, the advanced practice registered nurse, the nurse practitioners, they're more commonly called. I know there was a lot here, but we want to stress this because it's important to never become complacent. Again, you're going to be working long hours out on the floor, long hours at the bedside. Some of these patients can have med lists as long as your arm. It's depending on your specialty. Some of these patients take a lot of medication. And we never want to get complacent. We want to be very careful because unfortunately, a med error can have extremely detrimental effects on a patient. And we want to make sure we have everything exactly right to both protect yourself as well as that patient. But anyway, that's all we got for this chapter. I'll see you in the next slides.